Hello, everyone. I'm Paul Marji, and on behalf of UPMC Children's Hospital Pittsburgh, I'll be presenting Metopic Craniosynostosis versus Benign Metopic Ridging, Diagnostic and Management Trends over a 15-year period. We have no disclosures. So the metopic suture separates the frontal bones and is the first calvarial suture to physiologically close, typically between 3 and 9 months of age. Metopic craniosynostosis is the premature fusion and pathological ossification of the metopic suture, which leads to restriction of lateral growth of the frontal bones, resulting in a triangular head shape known as trigonocephaly. The associated decrease in intracranial frontal volume requires operative correction to allow proper brain growth as well as for aesthetic considerations. A palpable or visible ridge at the metopic suture line can either indicate metopic craniosynostosis or can be the result of physiologic closure of the metopic suture known as a benign metopic ridge, which is a normal variant and occurs in 10 to 25% of infants. Unlike metopic craniosynostosis, benign metopic ridging is not associated with trigonocephaly and therefore is managed conservatively and does not necessitate operative correction. However, there is a wide range in severity of metopic craniosynostosis, and in less severe cases, it can present similarly to benign metopic ridging. The diagnosis of metopic craniosynostosis is often determined by physical examination to assess for associated forehead narrowing, bitemporal widening, hypotalorism, and epicanthal folding. Since the metopic suture is the only suture to fuse during infancy, it is the most difficult craniosynostosis to diagnose. So at 2 months, a palpable metopic ridge could be a result of premature fusion or physiologic closure. CT imaging is helpful in diagnosis, but there is no standardized criteria for diagnosis. The decision on diagnosis is based on a subjective assessment of CT imaging, resulting in variations in operative management based on the surgeon's personal thresholds. The literature also shows that the incidence of metopic craniosynostosis has been increasing over the past years and now occurs in 1 to 5,200 births and accounts for up to 30% of craniosynostosis cases, now making it the second most common type. The increase may be related to improved diagnostic abilities and awareness, but there may also be underlying factors influencing a true increase in incidence. So it's multifactorial. The aim of this study was to investigate the demographic and perioperative characteristics of patients surgically treated for true metopic craniosynostosis and evaluate changes in incidence of both metopic craniosynostosis and benign metopic ridging at our institution. This was a retrospective chart review and conducted on all patients evaluated at Children's Hospital of Pittsburgh from 2003 to 2018 for non-syndromic metopic craniosynostosis or benign metopic ridging. Demographic, perioperative, and long-term outcomes data were collected. The rate of disease incidence was evaluated during this time period. From 2003 to 2018, 84 patients were diagnosed with benign metopic ridging and 95 patients were diagnosed with metopic craniosynostosis. Of the 95 patients with metopic craniosynostosis, 63 or 66% underwent FOA. 23 patients were managed non-operatively due to mild disease. 2 patient families refused surgery, 5 patients were lost to follow-up, and 2 patients were awaiting intervention at the time of the study. Of the patients undergoing FOA, the mean age at diagnosis was approximately 6 months. Approximately 70% of patients were male, 89% of patients were white, 57% of patients were from multiparous mothers, 45% of patients undergoing FOA were found to have an associated submucous cleft palate, and approximately 49% had deformational plagiocephaly. The mean age at intervention was approximately 14 months at a mean weight of approximately 10 kilos. 1 patient was found to have elevated intracranial pressure. The mean SEBL was 300 cc's, and the mean blood transfused was 25 cc's per kilo. Only 3 patients required postoperative blood transfusion. There were a total of 5 dural lacerations requiring repair with no subsequent evident CSF leak, and only 1 major complication of hypoglobus of the left eye, which required a take back to the operating room for examination under anesthesia, but there was no evidence of extraocular muscle entrapment. The mean time spent in the ICU was 1.2 days, and a mean length of hospital stay was 4 days. The mean total length of follow-up was 3.5 years, and at long-term follow-up, some of the aesthetic considerations were supraorbital retrusion, temporal hollowing, and persistent calvarial defects. Over the study period, there was an increase in the number of patients diagnosed and treated for metopic craniosynostosis, as well as the number of patients referred and diagnosed with benign metopic ridging that did not undergo surgical intervention, as can be seen in the left chart for metopic craniosynostosis with an increase over time, as well as the right chart for benign metopic ridging, also demonstrating a positive correlation of increase in time. So to conclude, the treatment of trigonocephaly with FOA is associated with a low complication rate. There appears to be an association of submucous cleft palate and deformational plagiocephaly with metopic craniosynostosis. There has been an increase in both the number of patients seen for benign metopic ridging and treated for metopic craniosynostosis over the study period, which may indicate increased awareness of the condition by providers. It's unclear if there is a higher predilection to intervention based on this data. Currently, there's no gold standard for how much associated orbital frontal dysmorphology should trigger surgical intervention, and though physical examination and CT imaging is a diagnostic standard for metopic craniosynostosis, there is still wide disparity of opinion among craniofacial surgeons regarding the diagnosis and management of mild cases. Techniques such as machine learning algorithm to combine statistical shape information and craniometrics with expert rating to generate methods of measuring the severity of metopic craniosynostosis may assist in surgical decision-making. Thank you.